So MABAs are the combination of a beta agonist and an antimuscarinic in one molecule. So theoretically, the delivery of both active ingredients to the same site in the lung could facilitate additive and even synergistic interactions, so that when you give a monotherapy compared to a dual therapy, you sometimes hope to get more than a simple addition, and that's the synergistic interaction. And the delivery to the same site might make this better. Now, there's no clinical evidence to support this, but that's the theory. There's also a simplicity in terms of giving a patient just one drug. So traditionally, to give a beta agonist and an antimuscarinic long-acting, we would give 2 drugs. Giving just one drug is simple for the patient, one inhaler, and also in terms of side effects, it might limit the type of side effects that patients might potentially experience, although generally these are safe drugs and few patients experience side effects that stop them taking these medicines. So there are a few MABAs in clinical development. One that's being shown here is a MABA under clinical development with AstraZeneca. And this study shows an increase in lung function in COPD patients that is greater than some of the well-established monotherapies that we use in clinical practice. Indicaterol as a monotherapy and tiotropium as a monotherapy. Now, we would expect a MABA, because it has the combination of 2 bronchodilator mechanisms, to be better than these monotherapies, and it's very encouraging that this was seen in this clinical trial. What we need to see now is agents like this being compared to dual bronchodilators such as indicaterol plus glycopronium, Ultibro or Spiolto, tiotropium plus olodaterol. And that would really tell us whether MABAs are an advance on dual bronchodilators. So the TRILOGY and TRINITY studies being presented at this Congress finally give us an evidence base for the benefit of triple therapy in COPD. So triple therapy is an inhaled steroid plus a long-acting beta agonist plus a long-acting antimuscarinic, all in one inhaler. So in this case, it's the combination of beclomethasone plus glycopronium plus formoterol given twice a day. Although triple therapy in separate inhalers is commonly used in clinical practice, actually the evidence base for its effect on exacerbations is lacking. We know that triple therapy provides benefits in terms of lung function and also in terms of patient-reported outcomes such as health status, but to date we have not had convincing and robust evidence regarding its effect on exacerbations. So the TRILOGY study was a comparison of this single inhaler triple therapy against an inhaled steroid and a beta agonist. And it showed a positive benefit in terms of exacerbations. And there were also, as expected, benefits in terms of lung function and patient-reported outcomes. The TRILOGY study, the TRINITY study, showed a benefit against a long-acting antimuscarinic, tiotropium, alone. Again, in terms of all the outcomes I just mentioned. So this finally gives us an evidence base for an approach that we commonly use in clinical practice. One of the fixed dose combinations that we're using more and more is the dual bronchodilator combination. Long-acting antimuscarinics plus long-acting beta agonists all in one inhaler. Our use of these inhalers is slowly growing as we get more confidence that, on the one hand, that they're better than a long-acting bronchodilator monotherapy in terms of how patients feel. And on the other hand, we're now getting more and more information from the SPARK study, from this FLAME study, that these dual bronchodilators positively reduce exacerbation rates. So these medicines are now becoming standard therapies for patients who do not experience exacerbations and for those who are frequent exacerbators.